You are listening to Medscape's In Discussion series on breast cancer and HER2, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathy Miller, Valve Lentero Professor at the Indiana University School of Medicine, Department of Medicine, Hematology Oncology Division. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hi, I'm Dr. Kathy Miller, and welcome to Medscape In Discussion podcast series on breast cancer and HER2. Today, we're going to tackle the HER2 ultra-low breast cancers. To join me in talking about that topic, I'm delighted to welcome Dr. Francisco Esteva. Dr. Esteva is a professor of medicine at the Zucker Medical School at Hofstra Northwell and chief of the Division of Hematology and Medical Oncology at Lenox Hill Hospital in New York, which is also part of the Northwell Health Cancer Institute. Welcome to Medscape In Discussion Breast Cancer and the HER2 podcast.
Thank you. Thank you, Kathy, for the invitation.
So, Francisco, before we get to ultra-low, I thought it would be helpful if we start at the beginning. What prompted investigators to start looking at HER2-targeted therapies in tumors that have lower levels of HER2 that we would have considered HER2 negative?
This was from previous trials where patients with what was considered HER2 negative, meaning HER2 1 plus or 2 plus by immunohistochemistry or negative by FISH, in some studies looking at trastuzumab deruxtecan, there were responses in patients which had lower levels of HER2, and that was intriguing and different from what we had seen before with the first therapies like trastuzumab, Herceptin, or even the trastuzumab DM1, where there were really not significant efficacy in patients with low levels of HER2. So the trastuzumab deruxtecan trials in patients with advanced breast cancer, again, is what prompted the study of this antibody-drug conjugate in patients with lower levels of HER2.
So after seeing benefit in those that were HER2 low, now we have to add a new term, go even lower to HER2 ultra-low. How is that defined, and how will physicians in practice know if they're dealing with that new category?
So HER2 is important to understand the way we define HER2 positive and HER2 negative, and now that's been divided into low and ultra low through negatives to if that exists. So basically, by immunohistochemistry, when tumors are 1 plus or 2 plus and FISH negative, those were considered HER2 negative, but again, based on some of these clinical trials, they were considered HER2 low, meaning there was HER2 expression assessed by immunohistochemistry at low levels, 1 plus or 2 plus, even though there was no gene amplification. The HER2 negative in that setting, when the HER2 low was defined, basically the difference between 0 and 1 plus was very low expression in up to 10% of the cells, and that was considered HER2 low, initially HER2 negative. The HER2 ultra low is when we see some expression of the HER2 protein in 1 to 10% of invasive breast cancer cells. So that used to be called HER2 0, and now we are calling it ultra low. So we have the 0, which is no expression at all, no signaling, no staining on immunohistochemistry. That would be 0 with nothing there. If there is 1 to 10% of cells with some expression, that is not complete membranous staining. At low intensity, we would call it ultra low, from 1 to 10% of cells, or 1 to 9%, and then more than 10% would be considered low if the tumor remains 1 plus or 2 plus with FISH negative results. So our pathologists can tell us or decide whether it's 1 plus or 2 plus. It's a little bit subjective, and that's where we need more quantitative analysis type of technology, but right now they can tell us if there is incomplete membranous staining, very low intensity, that's 1+, a little bit more intensity, more cells, 2+, but to call it 3+ or positive, traditionally we have to see, or they have to see, complete membranous staining of the whole cell membrane in at least 10% of the cells. And that definition has also changed from 30% to 10%. And so there are different definitions of 3+ positive tumors. But basically, the ultra low is very low expression, very low intensity, incomplete membranous staining in 1 to 9%, I guess less than 10% of cells.
So I'm thinking back to the pathology reports that I've seen over the years, and I've certainly seen some of the details of the proportion of cells staining when they've listed it as 1+ or 2+. I don't think I've seen that when they list it at 0. And that's going to become a crucial clinical question because the HER2 ultra lows would have been categorized as 0 on their initial testing. So we are either dependent on a pathologist being verbose enough to say, I saw a little something, but it wasn't enough to say it's 1+, so it was 0.
Yes.
Or we have to go back and get them to retake another look. Has that been your experience as well?
Yes. The way we see it in the pathology reports, what we call today ultra low based on the clinical trial, the Destiny Breast 06 with the trastuzumab deruxtecan, those would be shown as HER2 negative, and if the pathologist states the level of IHC would be 0, I don't think they're defining the ultra low very well at the moment.
So, Francisco, I know I'm having a problem in my clinic finding these patients, and I think I may not be alone. Many of the pathology reports simply listed patients as HER2 0, and they didn't tell me it was 0 with a small amount of staining in 5% of cells or 4% of cells. So if it just says 0, I feel a little uncomfortable because I don't know if it's 0, truly 0 as we understand it now, or was there some staining there, but just not enough to meet the ASCO-CAP classifications for saying it's 1+. When people in practice come up with those formerly known as HER2 0 reports, how do they sort this out? How do they know if this patient might benefit from TDXD?
Yeah, that's a real issue in clinical practice because until the data with TDXD was presented at ASCO in 2024, we did not need to know beyond 0, 1+, 2+, but patients who were traditionally reported as immunohistochemistry of 0 could be what we now call ultra low. If there was some staining, even though it was incomplete membranous staining or very low intensity in some cells, up to 10% of cells, those would be considered immunohistochemistry 0 by the ASCO-CAP guidelines in the past. So if we see a new patient, we are asking our pathologist to actually quantify and see if there is any staining in any percentage of cells to ensure that we are not missing any patients with HER2 ultra low, and of course low, which would be more than 10% low intensity, as we call today 1+. So between the 0 and the 1+ is a real challenge. And if we see a report with immunohistochemistry of 0, I would ask the pathologist to go back and review the slide or repeat the test and see if there is any staining that would justify the use of TDXD in these patients.
So there are a couple of other practical issues that come up. One is that some of these patients' primary tumor may have been many years ago in another facility, may not be available for testing. If she does not have, other than bony metastasis, to biopsy, can we still get the information? And is this a test that could now be applied to circulating tumor cells for those patients for whom biopsy might be difficult?
I think for circulating tumor cells, this technology has not been validated at that level. Of course, you could extrapolate and you see if you are able to get tumor cells enough to do some immunohistochemistry and you see any staining, that would be probably justifiable. But I think the technology is not there yet. So I would try to rebiopsy the patient and get tissue. But yes, if there is a way to assess the tumor cells and there is any expression of HER2, in my opinion, it might be acceptable to consider this therapy for patients with limited treatment options, but it's not, I don't think, a technology that's been proven to be as effective as the regular immunohistochemistry. So a rebiopsy for the differentiation between 0 and 1 plus might be necessary, in my opinion.
So the other thing that comes up and gives physicians angst is the patient who has had several different biopsies and the HER2 results don't match. They may go from, frankly, 0 or ultra low to 3 plus. How do you deal with the heterogeneity of the tumor, whether it's inherent heterogeneity or heterogeneity that's arisen because of therapeutic pressure and development of resistance?
Yeah, that's a really important issue. We're actually trying to look at that in a large database in the New York area, and we are seeing that more often than we thought, that patients would, looking at multiple biopsies, we see different levels of HER2 expression. It's something we are really looking into actively, and basically there is heterogeneity, so there's some of it is clonal selection, sometimes it's treatment pressure. There are different hypotheses, could be also testing issues and testing heterogeneity. But the point is that this is not unusual, so we have to be aware and cognizant of that. And if a tumor is HER2 3 plus and positive, we generally treat the patient whether another tumor is less than that. So it's not such a big issue right now because we can use, let's say, TDXD in 1 plus, 2 plus, 3 plus. I think the bigger issue is, let's say, if your patient has 2 biopsies, they're both negative, and the report specifies that immunohistochemistry is 0, as you mentioned before. Is that where we need to ask our pathologist to go back and tell us what to do? But these different reports that we see in terms of heterogeneity and whether it's biology or testing changes, it's something that we see in clinical practice. I agree with you.
So the other complicating factor that still comes up is the few labs that prefer to just send everything for FISH testing, and they only send the sample for IHC if they have an equivocal FISH test. I'm assuming all of those samples need to go back, be sent for immunohistochemistry?
Yes, that is the approach. In our institution, we don't do that. We still do immunohistochemistry first. But for those who do FISH first, if the FISH is positive, of course, the patient can be treated with a number of therapies. But for patients with a FISH negative result, they should be doing immunohistochemistry to determine whether it's ultra low, low, etc.
So in our last few minutes, Dr. Esteva, I want to take you to your clinic come Monday morning when you have a patient with metastatic disease, HER2 low, cleanly documented in the pathology report. But she also has an ER positive tumor. So this is someone who has several different targeted therapy options. Where does using the HER2 low status fit in her treatment as you're thinking about her course?
So a patient like that with ER/PR positive, HER2 low metastatic breast cancer, if the patient has minimal symptoms or not extensive disease, I would still treat them with hormone therapy, let's say an aromatase inhibitor with a CDK4/6 inhibitor. And depending on the situation, we may continue with hormone therapy for a while. When the patient becomes hormone resistant, is that where I would consider HER2 therapy, like with trastuzumab with TDXD, and that would be my approach as opposed to frontline therapy with a TDXD, because I still think hormone therapy should be the frontline therapeutic approach.
Now, the other situation is the patient who's HER2 low and ER negative, and I'll throw in that they are PD-L1 expressing. Where does this fit in those patients?
Yeah, that's where we need to decide which ADC we should be using, whether sacituzumab govitecan or trastuzumab deruxtecan T-DXd, because they were tested in the HER2 low triple negative type of approach in the past, and they both seem to be effective. So I don't think we know exactly what's the right sequence, but if a tumor is a HER2, let's say 2+, I would prefer to use T-DXd as opposed to sacituzumab, but they're both probably will be used in sequence in that situation.
Thank you, Dr. Esteva. It's been fun talking with you about the issues that come up with this new classification of HER2 low. We've all learned that we will need to make friends with our pathologists and be in regular contact with them as we're looking at old pathology reports, particularly those that just listed a tumor as HER2 0 without additional information. Some of those samples may need to be restained, and we may need to push for new biopsies in those patients for whom archived material isn't available. These are patients who have lots of options for treatment, and we will need to continue to talk to patients about their goals of care, exploiting hormone therapy in those that are also ER positive, and lots of data to come, I think, that will help us best sequence the growing number of antibody-drug conjugates available to us. To our audience, thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on breast cancer and HER2. This is Dr. Kathy Miller for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Breast Cancer and HER2 podcast series with our host, Dr. Kathy Miller. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on breast cancer and HER2.